46-year-old female patient who is presented with swelling and pain in the knee and difficulty in walking with restriction of movements because of the size of the swelling, and she had a history of recurrent knee joint effusion. So on examination, knee effusion was present, swelling in the popliteal fossa. It was clinically it was 6 cm proximal to the popliteal crease, and distally it was 5 cm to the popliteal crease. The consistency was found, shear restriction of knee flexion. Only 50 degree of flexion was possible because of the large swelling in the popliteal fossa. And the another section, as you can see, the superiorly it is extending around 7 to 8 centimeter proximally. Distally it is around 6 centimeter. Though the entire length of swelling is around 13 to 14 centimeter. This is another images you can see. That the axial section, you can see the swelling is entirely engulfing the femur in the proximal aspect, covering the anterior and posterior, both the aspects. It is inhomogeneous, hyperintense plus hypointense on almost every section. These are also axial images going down. So that is the MRI report. There is moderate right knee joint effusion noted, the diffuse lobulated enhancing synovial thickening and internal T2 hypointense non-enhancing areas, multi-lobulated T2 hypointense lesions with intermittent areas of fluid is seen in the popliteal fossa. So you can see the extension to lower thigh region between deep to lower calf muscles and superficial to lower femur, and it was almost touching the posterior aspect of the femur. The size is approximately 110 by 62 into 135 millimeter. And it shows peripheral inhomogeneous areas of enhancement with major non-enhancing, poor enhancing T2 or T1 hypointense areas. So we take the decision, and after discussing with the patients and relatives, the prognosis was explained to the patient in risk of recurrence, because the diffuse PVNS is almost 50% of recurrence rate. We take to decide the dual approach, posterior plus anterior. Posterior first, and we have done it without tourniquet in prone position, then patient turned supine, and the anterior medial parapatellar approach done, and almost near total synovectomy was done. So that is the clinical image. This patient was turned prone. This is a superficial dissection, almost 15 centimeter incision taken in the S-shaped manner, and that is the superficial dissection. That is the deep dissection, almost entire swelling was exposed. We try to do it without tourniquet, and we almost doing the finger dissection, not using any sharp instruments, because it was very near to the vessels and neurovascular bundle. And whenever we go on the vessels are on the lateral side, so whenever we do dissection on the lateral side, we try to fill it with fingers. So that is the excised specimen. You can see it is entirely almost filling the kidney tray. So that is the picture after complete excision of the swelling. All the neurovascular structures were intact. Then the closure was done, and patient was turned supine position, and that is the anterior approach, and everything was excised. Fortunately, the cartilage was normal. That is the complete healing of the wounds, anterior and posterior. That is the range of motion that we gained. And that is histopathology examination. That is examination showed is a giant cell tumor of the tendon sheath. The PVNS is a group of disorders which are classified as a giant cell tumor of the tendon sheath. So diagnosis was confirmed. So the take-home points is a diffuse PVNS is a rare, locally aggressive, benign tumor-like proliferation of the synovial tissue. It is also known as the GCT of the tendon sheath. There is widespread joint line involvement, and sometimes there is destruction of the joint line margins and cartilage also. Patient present with chronic pain, swelling, recurrent knee effusion. It is high recurrence, almost 50%. This is done before 3 months, so almost we are observing the patient. And complete synovectomy often is recommended and is a good prognosis. Thank you.